Good afternoon, and thank you for joining us at this OzSAGE press conference. I'm Dr. Jay Mueller, an emergency physician. Before we start, I would like to begin with an acknowledgement of country. I begin today by acknowledging the traditional custodians of the land from which we all gather today, and pay my respects to their elders past, present, and emerging. I extend that respect to Aboriginal and Torres Strait Islander peoples who are here today. Just to get started, we will be going through our OzSAGE update, specifically discussing that COVID-19 has now become a leading cause of death in Australia. We'll start by reviewing some of the statistics in the recent reporting period, and then discuss how we're doing in residential care facilities with some general information, recommendations for proceeding through this pandemic and potentially turning things around to arrive at a better state. How to reduce infections in aged care facilities and also protections in those aged care facilities. I'll introduce each speaker as they come, and at the end, we'll make sure that we have time for questions. If I can ask that the statistics slides be put up, that would be great. So just as an overview, there have been just over 1 million reported cases in the last 2.5 weeks, with a significant percentage, 34.6% of those in patients younger than 30 years old. There are 761 active aged care outbreaks at present, 5,415 new cases, and 154 new deaths in the last 2 weeks in aged care residents. You can see the total cases and a breakdown by age in the upper right-hand corner. Next slide, please. In terms of vaccination, 77.18% of the Australian population have now had at least 1 dose of vaccine, and just about 53% have received a third dose of booster vaccine. You can see that we've plateaued in the last few months. Next slide, please. Regarding hospitalizations and deaths in the last 2.5 weeks, there have been 999 deaths. You can see a little spike there. That's a reporting anomaly, but consistently seeing high death rates. You can also take a look at the hospitalization rates and ICU utilization with ventilated patients with a breakdown by state. So we can see that COVID continues to represent a significant burden on the healthcare system with hospitalized and intensive care resource utilization in each state. And certainly the states that have recently opened their borders are bearing the brunt of that. So I think that covers where we are with statistics since the last reporting period. Now to discuss residential care facilities, I would like to introduce Professor Mark Tennant, who is a scientist who's been working with health data across the world for the last 25 years. His current focus is on examination of large data sets in the context of geographic information systems, and particularly COVID data. Mark, go ahead.
Thanks, Jay. Nice to be here today. And it's somewhat of a sad job to be reporting this data. I think there's some troubling parts to it. So if I could have the first slide, please. This data is actually data reported by the federal government each week through their website. So this is open data. What you're looking at here is a map of the clusters of cases in red and deaths in black by residential aged care facility. The size of the dots represent the number or a proportion of the number. And I've highlighted Sydney and also one of the newly opened border cities in Perth. Fundamentally, as of last Thursday, there were 750 active sites with clusters within them. And those 750 active sites are a proportion of the 3,100 total sites that we have in Australia. If you could move on to slide, please. More importantly, if we look at the new clusters, So in other words, those residential aged care facilities that didn't have a cluster the week before, but do in the current week, we note that the majority of those 750 sites with clusters are new clusters. And this is consistent with that we now know that approximately 77% of the 3,100 sites in Australia have at some point during the pandemic had clusters within them. Next slide, please. The lives lost early relative to cases, we can see from this, I'll show more of the detail of the data in a minute, but what I want to talk about here is to show that there is clearly a lockstep link between case number changes and lives lost early. I think that's important in the discussion of these being elder citizens and the discussion of for or with. Clearly at a population level, these are lives that appear to be taken early by a virus cluster outbreaks. Next slide. And if we dissect the federal data and have a look at the week by week numbers as opposed to clusters, because remember clusters can spread over a number of weeks, we look at the case numbers since the late January, we see that we got to a low number in April, and then from April thereon, case numbers have risen and have plateaued at about 2,500 cases, new cases each week. This is the weekly cases spread by state. And as one would expect, if we move to the next slide, you can see here weekly deaths in residential aged care facilities from that same starting date. We can see the reduction through to April after the events of December, January. And since April, we've seen an ever-growing number of weekly deaths in residential aged care. We are now looking, last week it was 80, and the data is released today, and I expect this number to probably continue upward based on what we're seeing, that residential aged care deaths at 80 is a life lost early every 2 hours. So we still have a significant issue of deaths in residential aged care. I will now hand back to Jay to speak to the next candidate.
Thank you, Mark. I'd like to introduce Dr. Karina Powers, an occupational and environmental physician located in Western Australia. She'll be discovering some recommendations for turning the pandemic around.
Thank you, everybody. Please start my slides. So COVID-19 has become a leading cause of death in Australia, and OzSAGE is making an urgent call for action. Next slide. In February, we released OzSAGE statement on deaths in Australia from COVID-19, but here we are, it's only May, and over 70% of more than 7,926 reported deaths from COVID in Australia have occurred this year, and we're not even halfway through the year. The Australian Bureau of Statistics has just released that of the deaths that have occurred up to April 2022, COVID-19 was the underlying cause of death 89.8% of the time. Next slide, thank you. So deaths between 20 to 50 years, there were 896 people, sadly, and there have been 13 deaths in children and adolescents. The Australian Institute of Health and Welfare has calculated that around 8 to 9 years of life have been lost per person dying of COVID in the first wave. It's a significant loss of life. We're on track to reach approximately 15,000 to 18,000 deaths from COVID in 2022. And this is up to 16 times the annual road toll and about 6 times the deaths from the worst recent flu season. This is a significant loss of life. Next slide, thank you. Our Aboriginal and Torres Strait Islander people are suffering. There have been at least 145 deaths, and almost all of these have occurred this year. Aboriginal and Torres Strait Islander people are 2 to 3 times more likely to die from COVID than non-Aboriginal Australians of the same age. Next slide, thank you. So we have some recommendations for government from OzSAGE. We would like to see public health education, a campaign on the airborne nature of COVID-19. We've had campaigns before for smoking, road crashes, skin cancer. We need one for COVID-19 being airborne. We need to communicate the need for mask wearing in all settings where transmission is likely to occur, such as indoor venues with poor ventilation. And we best make P2 or N95 respirators, which are high quality masks, freely available to the community. Next slide, thank you. If we improve vaccine access, we will have less cases and less deaths. So we need to increase our 3rd and 4th dose rates of vaccination. Next slide, thank you. We best legislate standards for safe indoor air through ventilation and filtration, and educate and provide toolkits for ventilation assessments, such as CO2 monitors too. Perhaps people can hire these out. It would be good to offer grants to improve ventilation infrastructure. One state, Victoria, is already doing that, and develop plans to guarantee healthy air quality, especially in high-risk places such as aged care and residential facilities. Next slide, thank you. We best provide free and easily accessible PCR testing and free rapid antigen tests to households. In some states, they are doing that. And also transparent reporting of cases, hospitalizations, and deaths from COVID. Next slide, thank you. We should improve access to healthcare. Some patients, they have symptoms, but they aren't able to access antiviral medications or budesonide through their doctors. There's no clear pathway necessarily. And we need to make these pathways very clear to patients and doctors, how to access these important things that prevent deterioration. We need to improve access for primary care treatment. There are people who are unable to access a GP. Next slide. So the status quo cannot continue. There's just so many people dying still. And a new thing that has not been tried by many states and territories is to involve occupational physicians, occupational nurses, and occupational hygienists embedded alongside public health. And these professionals can advise on practical adjustments to prevent future outbreaks, so that we're not just reacting to outbreaks, but we are making it such that in the future, the airborne viruses, COVID and whatever other airborne virus is attacking us, will not cause problems. We need to support the efforts of the National Aboriginal Community Controlled Health Organisation and listen to them about what they need to mitigate the effects of COVID in their communities. Thank you.
Thanks, Karina. I'd like to introduce Professor Jeff Hanmer, who's an adjunct professor of architecture at the University of Adelaide, who is the principal and managing director of Arena Architecture, and has an interest in how air moves through buildings and how it affects viral transmission. He's going to discuss reducing infections in aged care facilities and improving ventilations in those settings.
Hi, everyone. I'd like to talk about a bit of history first. We might remember back in the second wave in Melbourne, which was in 2020. Seems like a long time ago, but not really that long ago. We had a lot of infections in aged care facilities. In fact, when we look at infections, we find out that the majority of infection sites were aged care facilities. And so it's no surprise to find that the same thing is happening again now. What is surprising is that we've already in 2022 killed twice as many people as we killed in the second wave in Victoria in aged care. So the death toll at the moment is about 75 people a week on average. And as Mark has shown us in his graphs, that's going up. Now, back at the start of 2020, when the pandemic was new, people didn't or weren't sure about how the virus was transmitted. And so you'll remember we were washing hands and wiping down surfaces, doing lots of deep cleaning and so on. But by the middle of the year, it was entirely obvious to many scientists that COVID was being transmitted through the air. So it was an airborne disease. And part of the reason for the high rate of infections in Victorian aged care at the time was because all of these buildings are naturally ventilated. In other words, they rely on openable windows. And because it was cold, all of these windows were shut. So it exacerbated the problem of transmission. And that's essentially why we saw extensive transmission in that environment. So I was concerned about this. I wrote an article in The Conversation, and then I wrote to the Minister on the 7th of September. This is Richard Colbeck, saying that there was an issue with airborne transmission. And the Minister wrote back on the 28th of September. I have the letter here. And he said, or his representative said, current evidence suggests that COVID-19 is most commonly spread from close contact with someone who is infectious. It can also spread from touching a surface that has recently been contaminated with the respiratory droplets, cough or sneeze, of an infectious person, and then touching your eyes, nose or mouth. Well, of course, that was wrong then, and it's still wrong now. And what we haven't done in the interim is done anything about improving ventilation in aged care in a systematic way. What we do need to do is to urgently institute a program to require better ventilation in aged care. Now, we've done some work on this, and the cost of providing upgraded ventilation in all of the aged care facilities in Australia, and I defer to Mark, but I've got that down as being 2,695 separate facilities. I think I'm using the government's figures, but there are several figures floating around. But on that basis, I think we estimate that it would cost around $3 billion to upgrade all of the ventilation of these facilities, which, to put that in some perspective, that's 3 times the cost of the North Side Storage Tunnel in Sydney. And the North Side Storage Tunnel, for those of you who don't know, is a facility designed to prevent overflow of sewage into Sydney Harbour. So what it achieves is it makes it possible to swim in Sydney Harbour without getting an infection. That's what it does. And that costs $1 billion. So we're suggesting that we spend about $3 billion to improve air quality in aged care facilities with the aim of stopping people getting COVID, which will then reduce the number of deaths. So I think that's pretty good value for money. Thank you very much.
Thanks so much, Jeff. I'd like to return to Dr. Karina Powers, and she's going to discuss some protections for residential care facilities.
Please share my slides. Thank you. So we're going to quickly talk about practical protection measures for pandemic hazard control in residential care facilities. Next slide. Residential care in 2020 was grim worldwide. there were very sad COVID-19 outcomes. Between 19 and 72% of all SARS-CoV-2 related deaths were in residential facilities. And this includes Australia in those early waves. I've seen a figure of 76% quoted. So shortages in healthcare became obstacles to provide care for the most fragile of our people in this country and other countries around the world. There was a lack of standardized guidelines, and underfunding contributed. And this came from the impact of COVID-19 pandemic on long-term care facilities worldwide paper. Next slide. So we need to do things differently. We can see there are people still dying in numbers that are much too high. It's a leading cause of death, COVID-19 in Australia. We need to use vaccines plus. Our residential aged care worker COVID-19 vaccination rates are mapped by the Australian government, and you can access those. They're updated apparently every Wednesday. And whilst it appears that generally a third dose for the aged care workers are 90% and above in most areas, there are some areas that have a much lower coverage of third dose vaccination, about 60%. And we know that Omicron and the other sublineages and variants, 2 doses is really not enough to help people. We need to up that. So 3rd and 4th doses are very important to prevent hospitalizations and deaths for residents and workers. Next slide. This is a photo of a carbon dioxide monitor, which is a proxy for the amount of breath that's hanging in the air. And several papers support having safe indoor air, and Jeff Hamner, Professor Jeff Hamner has already spoken to that. Next slide, thank you. Now, respirators are high quality masks. They're also an integral part of Vaccines Plus. Cloth and surgical masks should be urgently replaced with respirators. And whenever there's community transmission, all staff throughout the aged care facility where air is shared should be wearing these. Wearing a respirator will reduce the risk of infections by around 2.5 times compared to a regular surgical mask. And respirators have to standard. So there's P2 in Australia, N95 in the US, FFP2 in Europe, and KF94 in Korea. And we have an OzSAGE document. We urgently need better masks, respirators, and that's on www.ozsage.org. Next slide. So there has been studies showing how staff interact in the community, and when there is community transmission, it's clear this is a risk for the aged care or residential facilities. Staff can bring that into the facility. So it does help if the government keeps the cases outside the facilities in the community low. It does save the residents. Next slide, thanks. So in the US, there are about 40% of the COVID-related fatalities as of August 2020. It was a significant proportion of the deaths. And when they looked at the smartphone data, this study on nursing home staff networks and COVID-19, they found that 5.1% of the individuals had entered 2 or more facilities, and that connections were likely arising from contractors and staff working at multiple facilities. And around half of the nursing home cases could be attributable to staff moving between facilities. So it is important to increase the amount of hours and permanency for staff wherever possible to decrease the amount of crossover. Obviously, some staff will move between homes, and there's no way around that. But that's where it's good to have, say, an occupational physician look at crossover workers and make sure controls are in place to prevent spread of infection. Next slide, thanks. And certainly it's been found that to have professional medical staff involved in disease control in facilities helps cut the risk of an outbreak. Next slide, thanks. It's also the quality of staffing and how that is structured. If there is good facility level leadership and the different sectors collaborate, then it will help with success. Staff can represent a substantial transmission risk, and it's important to make sure there's good systems in place. When you have more staff in the facility, there's more risk. If these people are well trained and well qualified, it does help drop transmission rates, and they can oversee others and teach others as well. Next slide. We need to keep up our testing and surveillance, and serial universal testing of residents and staff is considered crucial to cut risk of infection in residential care facilities. Next slide, thanks. So again, we need to prevent new outbreaks, not just react to outbreaks. We need to bed down protections in our residential care facilities so that these outbreaks do not occur or occur much less often, and this will save lives. So again, having a team of occupational physicians, occupational nurses, occupational hygienists embedded alongside public health in every state and territory to look at outbreaks will be helpful to really nail down why we are still experiencing infections and deaths in our residential care facilities. Similarly, teams could review what is happening in our schools. We are continuing to suffer outbreaks in schools, loss of staff, loss of students, and other organisations. If we can drop that load of disease in the community, then there'll be far less carried into residential care facilities. Thank you.
Thank you all for your time, and that was wonderful. We can move on to answering some questions now, and I'll direct them to the appropriate person.
I have a question for Mark.
Yes.
Mark, in regard to what we see in the media about dying with or dying from COVID, and you've looked carefully at the data, what can you say to that?
Yeah, that's a great question. And I think the answer, I wished it was clearer, but it's often not clear. And the first thing I want to point out that comorbidities, my memory of it is the general population outside residential aged care, comorbidities is 50% of us, including me. So, comorbidities exist for an entire population. What we look at is at a population level, if you look at the relationship between cases and deaths, they have risen and fallen in lockstep in aged care. So the data that we actually can see directly at the population level indicates strongly that this is lives taken early. This is not they died with a concurrent COVID infection. There are clearly some pieces of data around to help us. You quoted or someone, I think it might have been Jay, quoted the Australian Bureau of Statistics data that shows it's well above 80%. There's some work out of Queensland that showed that it was quite high as well. I think that was 75% or something. So there is data around to support it. But I think what you see in that lockstep relationship between the ebb and flow of cases is a very strong population level indicator that the good majority of this story is about lives taken early from COVID infections. Thank you.
Thanks, Mark. Melissa Sweet, you have a question?
Thank you very much. I've actually got a few questions. I hope that's okay.
Yeah, sure.
So and I'll just throw them out there and see which ones who would like to answer. So the first question is really, you've put forward a lot of recommendations across a range of areas. Are they being implemented anywhere now across Australia? I know there's a lot of variation between the jurisdictions. And if not, who needs to drive them? So that's my first question. Second question is, you might think it's a political question, but really I think it's about being real at this stage of the election cycle. And that is, does it make any difference to your concerns who wins the federal election? Do you think, I guess, your assessment of what difference that might make to acting on these concerns. And then the third question is your key advice to the next Prime Minister and Federal Health Minister, your first sort of 3 things you'd like to see them do on COVID.
Karina, maybe you can answer whether some of those protections that you discussed are being implemented yet.
So there's a lot of variation around the country with what protections are available. So for instance, in Western Australia here, we've been receiving free rat tests to households and into workplaces, but not everywhere is receiving an adequate number of rat tests. Also, I think I haven't seen any real distribution to the community of N95 or P2, and no real education campaign. And no real campaign on safe indoor air, except Victoria really has started to do well on that, I've noticed, with their grants, etc. So it's really patchy. And what would be good would be to see coordination and recruiting all the professional specialties that can assist in dampening down this pandemic and helping to prevent outbreaks in the further pandemics. I notice we've apparently had monkeypox in Sydney now. And that means using professionals such as occupational physicians now more widely than they've had, and embedding them into government panels to work alongside public health, because they are the worksite medical safety specialists. So there is lots more that can be done. It's going to take coordinated action, and it's going to take people working across their different silos and having the will to listen to other professions, and having a will to listen to the people such as the National Aboriginal Community Controlled Health Organisation, really about what they need. It's going to take listening and coordination.
Look, Melissa, for aged care, of course, the responsible government is the Commonwealth. So it's responsible for aged care throughout Australia. Have they been doing anything on ventilation? Answer, no. Should they be doing something about ventilation? Answer, yes. And this is now well overdue. The correspondence I mentioned from Colbeck came to me in 2020. We're now getting on for 2 years down the track, and we just haven't made a lot of progress. So it's dependent on the actions of individual aged care providers. There's no coordinated action by the government, which is a shame. I'm just going to essay an answer to the question on does it matter who wins? I think it does, simply because the only promise on the table at the moment is from the ALP to hold a summit into COVID and what can be done about the continuing high levels of infection. I don't think there's been a similar promise from the LNP. So on that basis, it does matter. If anyone's got anything to add to that, feel free, but it certainly is a distinction between the two parties at the moment, on my understanding.
I'll add to that, Jeff. It's a good point. OzSAGE is apolitical, but we do like to present facts and sound advice made up of multiple independent professionals, and we would hope that the parties would listen and help save lives. COVID-19 is a leading cause of death in Australia now. We really need some action. So let's hope that whoever gets in will put their shoulder to the wheel and get moving on this with some practical action.
Could I add also, Melissa, and you know me well, I'm going to talk data. The transparency in the data that is presented, I think everyone can do better. And I'm particularly concerned that the residential aged care data, that as it's released every Friday, I have to use a bunch of computer scientists to dissect out to make those graphs that you see. It is not transparent in that sense. And frankly, there has been multiple significant errors over the weeks gone by in that data as it's provided. So I think the issue of, and I think this is across the board, not only residential aged care, but I think it goes to hospitalisations and ambulance services and the whole sequence of things. The murkiness of the data has impeded expertise that could assist any government with acting on the problems at hand.
I might just answer just for a moment, if that's okay, about protections in schools, in fact, which has been my area of interest. So I've done some work in my own children's school to design a system to mitigate or to reduce the likelihood of transmission, and sort of combining ventilation and filtration. And that has brought some people to me asking for help in doing things in other states. So in New South Wales and in South Australia. And so in my work, and also in cold calling a bunch of schools here in Queensland, I haven't found any advice that matches what Victoria has done, which initially was an organized approach to getting some filtration into classrooms and a test to stay program. And it looks like they've probably dropped or are in the process of dropping a mask mandate. In South Australia in particular, the response that some people who are trying to push for safer schoolings are getting are that HEPA filters don't remove carbon dioxide, so they're not necessary. This is based on a fundamentally flawed understanding of the difference between ventilation and filtration. In fact, a HEPA filter was never designed to filter something that is the size of 3 atoms. It filters molecules out of air. So ventilation and filtration are related, but distinct entities in providing safe schooling. And if the people in charge of schools are inactive based on that flawed understanding, they're not going to progress their schools to a safer place than they are currently. And so Victoria has sort of been ahead of the other states in providing safer schooling, and the other states have provided little, if any, advice on how to provide reduced transmission. And one of the interesting things is that the schools don't understand that they still have an occupational health and safety requirement to their students, but also to their employees. And just because the government has not provided them with very specific advice does not relieve them of that obligation. And I can tell you, having designed one of these systems myself, that the cost per student and staff is far less than the cost of paying for backfill for one teacher for a term, which many schools are doing, in perpetuity right now. And also that it is far less than the cost of a single lawsuit when a teacher has a bad outcome from COVID. Now, to me, this is a moral obligation, and you shouldn't have to place it in economic terms. But if you need to talk to the people who are going to listen to this and only want to hear about dollars and cents, then it clearly pays for itself as well. It costs less than $500 a student to eliminate transmissions in one school. That's peanuts compared to what it costs to pay for a teacher for a semester. So we're not seeing protections in schools either. I have another question.
Joe was just going to pick up on that both schools and aged care are substantially naturally ventilated buildings. So under the National Construction Code, a building can be either naturally ventilated or mechanically ventilated. And for various reasons, aged care and schools are 2 types of public building which are, generally speaking, naturally ventilated, which is great if you can open the windows. But as soon as you shut the windows, you lose ventilation. And of course, in winter or the height of summer, when windows are shut to keep people thermally comfortable, ventilation drops away, and that increases the possibility of people contracting COVID if somebody in a class or in a residential aged care facility has an infection. So both of these building types present challenges which we previously haven't faced in our building regulation system. And we need to fix this because unless we fix this, we're going to have continued high rates of transmission in schools and aged care. And the cost of fixing it isn't a fortune. The total cost of fixing schools and aged care would be around the $13 billion mark, which is not a lot when we consider that in relation to other budget expenditures. So over 5 years, that would be about 5% of how much we spend on other infrastructure through the Commonwealth government's budget. And if we compare it to other things we spent money on, then of course we've just lost $5.5 billion on some submarines. And we probably did in something over $30 million on JobKeeper one way or another. So these are not, $13 billion is a lot of money, don't get me wrong, but it's not unreasonable when we consider the benefits. Now, this goes back to water again. If we consider what happened in the late 19th century, there was huge investment in sewering cities in Western Europe, which of course had a massive benefit in health and economic development. We spend very little on making sure our air is clean. So we probably need to think more about what we need to do to fund a program to make sure we have clean air.
We have a question in the chat from Professor Raina McIntyre. Should everyone who is over 18 be eligible for a 4th dose of vaccine? Who's best equipped to answer that?
I can say what I know from today, Jay, which is the CDC has moved to have their over 50s have a 4th dose. So some of this is to do, I think, with perhaps supply, and some to do with perhaps looking at waning. But certainly from my point of view, even shifting the percentage, even shifting the population protection, a small percentage, is really worthwhile with COVID-19 because it's a systemic disease. It gets into brain, heart, liver, affects all sorts of vascular parts in the body. It has about 8% long COVID despite being triple vaccinated. And that's significant in a workforce. You will have a lot of difficulty retaining staff. Some are talking about 20% staff absences. And also when staff are there and they've been unwell with long COVID and have brain fog, for instance, they may not be sharp enough to do things such as safety critical work. So really, I find that 4th dose vaccination very important for all workers from my point of view as an occupational physician.
Excellent, thank you. Do we have any other questions? If we don't have any other questions, I think we can probably say thank you to everyone for their time. I really appreciate it. It's been a pleasure talking with all of you, and we'll look forward to seeing you again in the future with another update.